So on a three,
Hmm.
2, 1, you can start, sir. Over to you.
Good evening, all, and welcome all of you for today's Cross Connect webinar. The initiative of Lupin Sinus Division. As we know, diabetes is a chronic devastating disease, and the prevalence of diabetes is increasing day by day. Today, over the world, the number of diabetes patients are almost 425 millions. And every year, 1.5 millions of the patients are dying because of the death from the diabetes and its complication. So management is crucial, and it is very much important to take the quality of life of diabetes patient towards the better level. So for the same that discussion, today we have the eminent speaker, Dr. Ramlingan Srinivasan and Dr. KVS Harikumar for the cross-connect discussion. Today we'll be discussed on the ADA ESD Consensus Report 2022 and the Indian perspective of ADA ESD Consensus Report, so that we can see the future drugs and how the paradigm shift of treatment has been occurred and how that will be beneficial to the patient who are with the diabetes and our viewers. So with this, I would like to introduce both the doctors. With their affiliation. So Dr. R. Srinivasan is a MD, MRCP UK, CCST UK, consultant in diabetes and endocrinology, GKNM Hospital, Coimbatore, Tamil Nadu. Welcome on board, Dr. Srinivasan. And our second speaker is Dr. KVS Harikumar, who is the MD Medicine, DNB endocrinologist, consultant endocrinologist, Magna Clinics Hospital, Hyderabad. So welcome on board, Dr. KVS Harikumar.
Thank you, Dr. Kunal.
So with this, I would like to request Dr. R. Srinivasan to have their words on the ADA-ESD consensus report further. So over to you, Dr. Srinivasan.
Thank you, Dr. Kunal, for your kind introduction. And I thank Lupin for arranging this cross-connect. My topic is about the EASD, ADA consensus. And I'm going to share my slide now. Can you see the slides?
It's coming, sir, but yeah, it's visible now, sir.
Okay, thank you. So I'm going to talk in the next 15 minutes about highlights of the ADA ESD consensus report about on 2022. So this is a non-pregnant adults with type 2 diabetes, and this is very relevant current management of type 2 diabetes, because you know, the two medications, either metformin or sulfonylurea. But we have now a spectrum of medications to treat type 2 diabetes, and we are more concentrating on patient-centric approach rather than glucocentric approach. So the objective of care is that you don't treat the hyperglycemia alone, treat comorbidities and also the complications as well. We are always, when a patient walks into the, we are doing a preventive job rather than we are treating the disease. So we are trying to prevent complications of diabetes rather than treating hyperglycemia. So we have to do the care in an organized and a structured way. So the other thing is social determinants of health and preferences of a patient, and individualized approach and shared decision making to treat the goal and strategies. So the other things are principles of care, which they are highlighting in the ABA and ESDA consensus, is about the structured educational program like DISMIS is about diabetes self management and education, and this includes lifestyle behavior, medication adherence, and self monitoring when needed, and self efficacy and problem solving. The other things are all are intervention targeting therapeutic inertia and timely treatment intensification and the intensification as well. So individualized and personal approach of the principles of management is that person-centered care is essential, and treatment behavior and persistence and adherence are necessary. So need to concentrate on of 5 to 10%, which confers metabolic improvement and weight loss of about more than 10 to 15% leads to diabetes as well. So
So you're on mute, I guess. So we faced a network glitch.
SGLT2 inhibitor or sorry.
You can switch off the video, that will help partly. Dr. Srinivasan.
Can you see the slides?
Not yet, sir. So what we can do, you can switch off the video. That will help us to reduce the network bandwidth. Yeah, we can see the screens and now. Sir, should I switch off your video, sir? Your slides are visible, sir. You're not audible, sir, actually.
Diabetes care is that you will have structured DISMIS, individualized personal and approach, and a weight loss of 5 to 10% or more than 5 to 10% would lead to disease modifying effect of the medication. Hello.
You're audible, sir. You can continue.
Okay. So decision cycle for person-centered glycemic management of type 2 diabetes is to review or and plan. So you have to discuss. I said that you need to that you are treating such condition, and what are the problems with the medication, and how you are going to approach their medication thing, and what the patient should be doing about emotional well-being, lifestyle and health behaviors, and tolerable medication should be discussed. When a patient comes into a clinic, we always discuss about what the patient was taking previously and whether they had any side effects with those medications previously. So implement the management plan after discussing the key characteristics of the patient, about the individual, about whether this patient would be taking the medication, following what you say, and following the lifestyle changes that you prescribe, and consider specific factors that impact the choice of treatment, like individualized glycemic and weight loss goals, and side effects profile of medication, impact of weight loss to a patient, and assess the cost and availability of the medication. So these things have to be discussed with the patient, agree with the patient about the SMART, which is specific, measurable, achievable, realistic, and time-limited goal, and implement the management plan. So you have to think about the cardiometabolic health of a patient with type 2 diabetes, and these are some of the physical behavior which would impact definitely the diabetes and the comorbid conditions, or the cardiovascular risk factor modification. Like if you're sitting or breaking a prolonged sitting, stepping, sweating with rigorous or moderate exercise, strengthening exercises, and adequate sleep, good quality sleep, and chronotype or consistent timing. So these all will affect. So whenever you are sitting long, it will affect the glucose level and the blood pressure, HbA1c, lipids, physical function, depression, and quality of life as well. Likewise, the stepping, increased sweating, and strengthening, all will be affected. The blood pressure, HbA1c, lipids, all will go down. The physical function will go up. Depression will come down when you do more physical activity, and the quality of life will definitely increase. That I have experienced myself, and I've recommended to a few other colleagues of mine as well, who have increased their physical activity, and they are feeling fit in their life after that. So glucose lowering medications and management of type 2 diabetes, there are various medications. You have to concentrate on the weight management. You have to concentrate on the CV risk, cardiorenal protection, and the medication for glycemic control. So if you give a medication, you have to consider all these factors if you are treating type 2 diabetes patients. So cardiorenal protective glucose lowering medications are many. As I said previously, there were only 2. Now you have metformin, sulfonylurea, you have thiazolidinediones, DPP4 inhibitors, SGLT2 inhibitors, and GLP-1 receptor agonist. Apart from alpha glucosidase receptor, alpha glucose receptor agonist, and things like that. So combination therapy meets the consensus objective. So if your patient is having higher blood sugar, you have to think about a combination therapy which would influence durability of medication, durability of glycemic control, and potential to address the therapeutic inertia. So potential impact on the medication burden as well, and adherence and persistence. So if you are giving polypill, the patient may not be adherent, and if you give in a single pill, the patient might be taking a simultaneous targeting of multiple pathogenic process of type 2 diabetes and complementary clinical benefits.
So the consensus recommendation is that if you have a CVD or a potential risk factor for CVD, either you have to consider GLP-1 receptor agonist with metformin or GLP-1 SGLT2 receptor inhibitor with a proven benefit to reduce the MACE. So CKD and EGFR, you have to concentrate on a renal benefit, then SGLT2 inhibitor would be the right choice to both reduce the kidney outcome and also the cardiac outcome. So SGLT2 receptor inhibitor should be used because they improve the heart failure and kidney outcomes as well. So what is the consensus recommendation for patients who have heart failure, CKD, and established CVD is background use of metformin and baseline HbA1c. You have to choose between GLP-1 receptor agonist or SGLT2 receptor antagonist. So consensus recommendation is you should not be differ for older people, because the meta-analysis shows that even in older people, the SGLT2 receptor inhibitor or GLP-1 receptor agonist have equal effect, and even in a younger patient with the early combination therapy would reduce these risk developing in these patients. So summary of PDA and ESD consensus that you should understand the local resources and individual social determinants of health, and you have to be empathetic to person-centered decision making, and support should be there, and provide DSMS, that is diabetes self-management and education and support should be there, which would improve the health behaviors, nutrition and activity of self-monitoring, and support cardiorenal health, that CV risk reduction and attainment of glycemic and weight goals should be there to prevent a complication and optimize the quality of life. Thank you very much for your patient listening. I would hand over to the next speaker to take over.
Thank you, Dr. R. Srinivasan, for your wonderful talk on the ADA-ASD consensus report and the glimpse of the patient-centric approach rather than the glucose-centric approach, and further the initiation of the treatment in those patients where the CV risk and other complications are more. So not with the HbA1c control should be looked after, but the combination therapy would be the more better choice. Yes, totally agree with your presentation. Yes, with this, I would like to request Dr. KVS Harikumar to have their opinion on the Indian perspective of ADA and ESD consensus report 2022.
Thank you, Dr. Kunal, and good evening, everybody. I hope I am audible and my slides are visible.
Yes, sir.
Oh, perfect. So after listening to Dr. Srinivasan about how best and what are the issues concerning perspectives about how to manage type 2 diabetes, we shall see some of the issues concerning the Indian patients and maybe select the possible drugs which are going to be more useful in our settings per se. So the talk will be under these three headings. Basically, one initial couple of slides about highlighting the burden of the diabetes overall, and maybe just about touching briefly about the separate Asian phenotype and what are the unmet needs in the management and how to overcome this unmet need in the current perspective with the available drugs. So these are the things which I shall be covering. If you look at the prevalence of diabetes in India, the original studies in 1960s and 1970s gave the prevalence of about 2% and much more concentrated in the urban than when compared with the rural areas. But say gradually it kept on increasing. If you look at the chart on the 1990 and in the 2019, the ICMR sponsored studies, this was the red was only in the Kerala, whereas now the reds are almost in 4-5 states. So that is what there is rapid escalation of the prevalence even in the same generation. So we should not be thinking that it is a genetic disease and there is some component of genetics to it, but predominantly it has to do with lifestyle, because all this change happened in a span of 20-30 years. So that is important to understand that more and more number of patients are increasing, which will obviously put a strain on the resources, which will obviously require a better control and to prevent the complications. And more important about the prevalence is the occurrence of the disease in younger age group, who are more required to be going out, required to be working out, and required to be a bread earning members of their families. So this is what the problem is, that there is a shift in the onset of diabetes to people in the younger age groups. If you look at, that is almost to the tune of majority of patients are between 30 to 65 age group. So that is where there is a big gap which happened, say from 12% to 17% rise between last 2 decades. So there is a peak incidence which is divergent right from this about 30-35 years. So the incidence is increasing and increasing in the younger age group. So these both are a cause of concern for all healthcare practitioners to address this and to give them a good life so that it doesn't affect their quality of work. Another important, almost similar data, if you look at the median age of diagnosis, the Asian Indians in the INDAP cohort is about 48 years. In the Dr. Mohan's cohort, it's about 47 years. So it's almost the same beat. I mean, ICMR INDAP study is almost spread over about 20 states, whereas Dr. Mohan's one is predominantly in the South Indian population, but still there is not much of difference. But if you compare with the European data, there is marked difference, because we are almost about 15 years early in the onset of the diagnosis of diabetes, rather than when compared with Europeans who are like, I mean, in the 6th decade of their life. So that is important to understand. Early diagnosis, as such, there is a further early as far as the pathophysiological changes happen, and the burden of living with diabetes is more. So you have a higher risk of having complications. So that is also important to understand. So after knowing that we are Asian Indians are a bit early to have, and then the prevalence is increasing, what are the challenges and what are the unmet needs in the management of the type 2 diabetes? One, obviously, there is a lot of issues as far as the more number of pills, more amount of dissociation with the regime, and then a lot of skipping happens. And non-adherence, whenever in a chronic care segment, it is important to have a patient-friendly regimen, which is going to be helpful to the patient, which is going to be easy and simple to the patient to remember. And if there is a non-adherence, that will lead to obviously suboptimal control, and this cardiorenal complications are more than when compared with the Western data, and almost 2/3 of patients of diabetes die because of the atherosclerotic cardiovascular disease. Some of the available drugs were discussed by Dr. Srinivasan, but issues is you may have the issues of hypoglycemia, weight gain, other issues concerning some of the available drugs, so which may preclude their usage in all patients. The difference of the Asian Indian phenotype is because of its early age of diabetes onset, and the beta cell mass is less. We have more insulin resistance, more visceral fat, and our diet is predominantly carbohydrate based. So you have a higher postprandial peaking, which will obviously result in more of endothelial damage and more of cardiovascular disease risk. And you have the typical dyslipidemia pattern of increase in the triglycerides and low HDL. So all this in a nutshell will increase the cardiorenal risk of the patient, which will have adverse outcomes. Some of the genome-wide association studies have also actually looked at some of the genes in these, say, fat-based genes or beta cell-based genes, but a lot of them are not in the direct cause-effect relation, more of an association. But yes, there are some relevant alleles which may give a clue about who are the patients who are likely to develop more complications, or maybe more likely to require insulin at an early date. So when you have to align the current challenges with the principles of care given by the ADA-ASD statement, you obviously will look at person-centered care. There is no doubt about it. You should always tailor-made your suggestions to the patient who is sitting in front of you rather than give a universal blanket suggestion. There is no doubt that weight loss is going to be beneficial at whatever be the age, whatever be the weight. Losing even a couple of kgs in the body weight will help tremendous benefit on the metabolic burden of the patient. And if you are able to lose by more than 10 or 15%, there may actually be a reversal of diabetes. And you should be more proactive in treating the patient rather than having a more sedated approach. So timely intensification and de-intensification both are required. Maybe you are using insulin, sulfonylureas, or any other drugs in the start because of higher A1C. But as the control improves, as the requirement goes down, there should be timely de-intensification also, because otherwise you are likely to cause a lot of hypoglycemia, which will further increase the burden on the healthcare systems. And education of the patient is the key factor, which will help in achieving all these objectives. And possibly self-monitoring will help in patient partnering with you as far as the management of diabetes is concerned. If you look at the ADA-ASD algorithm, the advantages of combining two agents was always given. Previous, say maybe a decade back or a couple of decades back, ADA and ASD were never used to talk about the combination therapies, or maybe to start with even two drugs. But now with more and more data emerging and more different pathophysiological mechanisms addressing with the same combination are being addressed. So they have also started talking about the combinations. So early use of combination allows tighter control versus monotherapy. So there is no doubt about it. And combinations are required if your A1C is more than 1.5 above the target. Because as a standalone OAD molecules, except for sulfonylurea, most of the other drugs have the potential to reduce A1C by about 0.7 to 1%. So if a patient has got say 8.5 and you aim to get them to 6.8 or 7, for achieving an A1C of 1.5%, you will require two drugs. So better to choose two drugs which are more functioning in complement to each other rather than negate each other. So the importance being, you should be selecting the drug, selecting the combination, and choosing the best possible combination to prevent the complications across the lifespan. That is important. And any of this vascular complication reduction will obviously help in reducing the morbidity and mortality in the given patient. So if you are looking at the combination of SGLT and DPP-4, the SGLT2 inhibitors, when they were launched, had the issue of being may not be suitable for Indian patients, may not be suitable for tropical climates, because we actually have a lot of sweat, and there may be a lot of issues of genital urinary tract infections, a lot of concerns regarding bone, all those things. But all of them have been seen not different than when compared with the trials in the clinical practice. And more so, a combination of DPP-4 actually reduce the risk of GTIs, which will help in actually preventing this rather than wait for the GTI to occur and then treat and then maybe look at combination. So maybe an initial combination would actually help in reducing the risk of genital tract infections. And this, beyond the say benefit on the urinary or genital tract infections, they target the different pathophysiological pathways without any overlap, almost target majority of the ominous octet defects, and which will result in a good improvement in the glycemia and adiposity. And obviously it reduces the metabolic and vascular risk. And being a single pill which has to be taken only once a day, it is safe, simple, and obviously improves the compliance of the patient. So this is one of the drug combination which has extremely relevant to Asian Indian patients with type 2 diabetes. And this is how it acts. The empagliflozin, we all know that is an SGLT2 inhibitor. it predominantly prevents reabsorption of glucose from the kidneys, and you have an indirect actions at the pancreas by increasing the glucagon and the increasing the beta cell sensitivity. But the increase in the glucagon, which is the detrimental effect in the diabetes, is offset by the combination of a gliptin, which reduces the glucagon and increases the insulin at the level of pancreas. And at the level of intestine, it has some action by increasing the GLP-1 and GIP. And the GLP-1 molecule has a lot of peripheral actions, which will help in controlling the most of the components of the metabolic syndrome, which include the BP, sugar, and cholesterol. So as a standalone molecule, the gliptin may be weight neutral, and gliflozin also is weight neutral, but does lead to maybe 3 to 4 kgs of weight loss. And both of them put together will have significant benefit on reducing the glycemic burden, along with collateral benefits or pleomorphic benefits of reducing the weight, reducing the BP, reducing the oxidative stress, and reducing the inflammatory markers, all those other benefits what they have been shown. And amongst the components of homogeneous octet, almost this combination affects 6 out of 8 components, either directly or indirectly, and this would, that is why, lead to the maximum possible benefit in the given patients about controlling the glucose, number one, sustaining the control over a longer period of time. These two things are more important, what you have achieved today and how long have you been able to achieve this throughout. So both of them are perfectly doable with this ideal combination. So the combination of EMPA and linagliptin, it's a early use is going to be beneficial because you're giving an excellent control to the patient. Treat early, treat right, and treat to target, and possibly you can use it along with metformin depending on your initial A1C, or maybe you can use it just after metformin if the patient is unable to achieve to the optimum level. The importance of it is both of them are like glucose dependent actions. So even if a patient has got an A1C of say 6 or 7, you are absolutely fair and safe to continue the drug because of the ongoing benefits of the usage of SGLT2 inhibitor. And the lower you keep the A1C for a longer time, the better delay you're doing on your complications, or maybe prevent the occurrence of these complications. So that is important. The consensus statement of ADA-ASD says that the benefits for cardiovascular and renal outcomes occur independent of metformin use. Some of the guidelines have started questioning the role of metformin as the number one drug, because there is not much of evidence to say that metformin is should be number one. Now that we have generated enough evidence with SGLT2 inhibitors, and early combination therapy should be based on the perceived need for additional glycemic efficacy, or if you require to use any cardiorenal protection, irrespective of the underlying metformin status, you should consider this as an essential therapy in the management. So that is as far as looking at, say, the CKD or the atherosclerotic cardiovascular disease data, you should be considering them as part of your armamentarium, irrespective of your control or irrespective of your metformins, irrespective of your GFR mostly. How is it relevant in Asians? The Asians have shown to have slightly more greater glucose-lowering efficacy with the use of SGLT2 inhibitors. Even similar data was seen with the gliptins also, because the Asian Indian incretin axis is a bit different from the Caucasians. So something difference is there. And subgroup analysis from EMPAREG showed consistent risk reduction for CV outcomes, mortality, and renal outcomes with EMPA in Asian patients with established CV disease. The DPP-4 inhibitors have shown higher efficacy in Asian patients, possibly due to increased DPP-4 enzyme activity. And you have a better A1C reduction for the same amount of DPP-4 inhibition than when compared with the Caucasians. And Lina effectively reduced hyperglycemia in Asian patients with uncontrolled diabetes, irrespective of age, BMI, renal function, ethnic subgroup. And sorry, the Carmelina and Carolina did show that you have a cardiovascular save doesn't increase the risk of heart failure or any adverse outcomes with the usage of linagliptin. So the combination of EMPA and Lina, there are benefits beyond glycemic control, which include sorry, as a standalone molecule, the EMPA reduces the LV chamber stiffness, resting mean arterial blood pressure, increases the hematocrit, plasma volume, and there is a reduction in the body weight and significant improvement in the diabetic individuals with the combination, along with reduction in the systolic and diastolic blood pressure. This is the clinical evidence in the A1C reduction with the usage of the EMPA-LINA combination as a initial combination in drug-naive patients. If you look at it, in the drug-naive patients, if your A1C is 9.3 at the baseline, you would get almost about 1.9% A1C reduction. Even in somebody who has got at 8%, your A1C reduction is almost to the tune of 1.2%. So these are safe and easily usable to achieve the optimum outcomes of below 7% in most of the patients. And the trials which have shown that reduction in the cardiovascular death, reduction in the hospitalization for heart failure, reduction in 3-point MACE and renal outcomes have been demonstrated with the usage of this combination. Some of the slides concerning the EMPA kidney are not there. EMPA kidney was published just a day back, a couple of days back in the NEJM, which actually gave the empagliflozin in patients who had GFR up to 20, and still they have demonstrated that there is across the board benefit as far as the worsening of the renal outcomes, requirement of dialysis, and doubling of serum creatinine. And even so, there is more benefit in the mortality rate as well. So the and this was seen even in patients with or without diabetes. So EMPA as a standalone kidney protection agent, that is proved beyond doubt. So it is safe and suitable for Indian patients because of its sustained glycemic control, improves both insulin resistance and beta cell function, helps reduce the body weight and blood pressure, reduces the pill burden, and overall cost effectiveness because of the pleomorphic benefits which the drug is going to offer. I've finished here. We shall be happy to take any questions.
Well, thank you very much, Dr. K.S. Harikumar, for dissecting the ADA-ESD conscious Indian perspective and giving the highlights of how the drug combination drug will be beneficial in those patients to reduce the further complications of renal and CV effects. Well, we'll be having a couple of questions. First question to the Dr. Ramalingan Srinivasan. What is therapeutic inertia and the combination of SGLT2 inhibitors role in that?
That's a very good question. Actually, what it is in type 2 diabetes, many times when a patient comes in, when a patient comes in with a HbA1c of 8.5, we would be, the initial guidelines always says that you have to try with lifestyle modification and metformin alone. And you have to go by stepwise by seeing the patient every 3 months or 4 months, do a HbA1c and treat according to the glycemic control. And if the HbA1c is high, you add another medication. By the time you try to achieve a good control, there'll be a lot of time lost for good glycemic control. So, and also there are a lot of things from the patient perspective and the doctor's perspective as well. Sometimes the patient might think that even they might gain weight, or they have hypoglycemia with the start of a new medication. And so they might be reluctant to start a new medication. Even if you can see in your day-to-day practice that if you want to, if you say to a patient that their glycemic control is poor, and if you are starting a new medication, they would say, no, sir, we will try to bring down the blood sugar by diet and exercise next time. So they say addition of another tablet would be a problem for them. So they try to bring down by, they say that they try to bring down by diet and exercise. This their point, and the doctor eventually agrees with what the patient says. And again, the doctor's side as well, they don't want to increase the pill burden to the patient, and this might delay the intensification of treatment to a patient. So this is therapeutic inertia. There's a lag of giving a medication to a patient to bring down the blood sugar is therapeutic inertia. That is answer. Thank you.
Well, what I understood from your way of explanation, that therapeutic inertia is the the resistance to the ongoing treatment for the diabetes. And yes, so that we have to shift the treatment to the better drugs where the blood sugar level also get control, and further the drug should give them more benefit toward the cardiovascular events if there is any risk to the patients. So what do you think the combination of linagliptin and empagliflozin would benefit in therapeutic inertia? Yes, sir. Yes, Dr. Ramalingan. Can you hear me?
Yeah. Yes. Yeah.
Is there any benefit where
we
can have with the combination therapy?
Definitely, if you give a combination therapy initially, it will be a less burden to a patient, and they might think that they are taking only one medication, but it is a combination which which will address various pathophysiological causes for diabetes, which will be more beneficial to the patient, bringing down the risk factors for the complications as well.
Okay. Thank you,
it will
Dr.
definitely
Srinivasan.
be useful to the patient.
Yes. So now for the question to Dr. K.V. Sarikumar, sir, yes, earlier what it was seen that the SGLT2 inhibitors, they have role pretty much towards the diuretic types of role. Now it sees that the role is towards the metabolic effects. So can you have your way of saying something, how the patient will benefit in that?
Yeah, see, if you have to lay a hand on the mechanism of benefit of SGLT2 inhibitors, the simple answer to say is unknown. But because as so many newer, pathways are being discovered, that how these are going to be beneficial, that is why they are called the wonder drugs of the last decade. Because say, be it, well established in diabetes, well established in heart failure, well established in kidney protection, well established in cardiovascular risk reduction. Okay, now initially we thought about having, say, just about diuretic effect, anti-hyperglycemic effect, some reduction in the blood pressure, maybe a 4 or 5 millimeters of mercury, all those things. So those are like, say, evident above the table very easily. Now, as more and more data is emerging, that why is it being beneficial in non-diabetic? Why is it being beneficial in non-obese patients? Now, some of the issues concerning the reduction in uric acid has come in. Some of the issues in increasing the ketone bodies where using alternate fuels has come in. Some of the issues concerning the reduction in the lipoprotein little a or altering the entire lipid basket has come in. So it is actually, as I said, there is not clear. But as long as, they're doing a perfect job, people are happy with it, and that's why one of the new drugs which has been, I won't say new, but a relatively new drug which has been embraced by across all specialties, leave alone the endocrinologists, leave alone the diabetologists, all those things, across all specialties put together, say, unlike, almost similar to statins, which lot of specialists use. So the same logic which applies to SGLTs, which is going to be one of the drugs, and you have at least, I would say, 10 different mechanisms which has helped. In a given patient, what is the maximum role? We don't know, but that is how the work is. There are, each has, it's like ominous octet. In a given patient, each one will contribute different mechanisms.
Well, thank you, sir. There is one more question. Means we have more couple of questions that, well, yes, SGLT2 inhibitor are more better way because of treatment, because now it is giving a holistic approach in the treatment of diabetes patient. But there is another SGLT2 inhibitor as well, dapagliflozin. So how you want to segregate both the drugs and the approach of treatment to the Indian patients?
See, the some of the drug, within the groups, within the same group, that is the SGLT2 inhibitors, some of them are the class effects, some of them are drug-specific effects. Now, obviously, you won't have any direct comparison between, say, EMPA versus DAPA to actually look at how best is what is doing in a given setting. But if you can only extrapolate the data from individual trials and then maybe identify or maybe find out that it is useful in a given setting. Say across the board for heart failure prevention, all SGLT2 inhibitors fall in the same basket. There is no doubt about it. Now, coming to further secondary or as far as the other cardiovascular issues are concerned, EMPA is the one which has shown to be more beneficial the more severe risk factors the patient has got. So higher the risk, you should maybe use it, the higher the potency drug or the best possible drug as far as giving you the best outcomes. Whereas DAPA did not show that much difference in such subset of spectrums. But as I am repeating, these are not direct studies comparing these two. So whatever the trial indications and trial inclusion criteria, if you have look at it, if you look at the original EMPA-REG outcome, the most severe cardiovascular disease patients were the ones which were included, and all of them have shown pretty much best outcomes and right from their mortality and everything. So you had a difference. I would only say if you want the maximum benefit, go to the empagliflozin than when compared with any others, and a time-tested molecule which is proven beyond doubt as far as its efficacy is concerned.
Well, there is one more question that which type of patient we should go for LINA-EMPA combination?
See, which type of patients, actually the all patients you should be going, there is no doubt about it, because you're looking at achieving an A1C of say maybe even a 5.6 or 6% without having any risk of hypoglycemia, keeping his metabolic milieu in control. So what the traditional thinking of say A1C of 6 or 7 was only kept because the drugs what we were using were sulfonylurea predominantly. Yes. So you had to balance the risk of hypoglycemia versus the benefit of good glycemic control, and then gave that optimum level of say 7% or 6.5%. But here you have an option of there is no fear of hypoglycemia in your mind. You can safely use even to a 5.8 A1C. Suppose you started with 7.5. The patient has come to maybe 5.8 or 5.9. You don't have to bother and stop. The issue being because you're continuing to provide the benefit to the patient. So don't go by that glucose-centric approach. You are correcting the pathophysiology by giving this combination. So use as far as patient is able to afford, number one, patient is able to tolerate, number two. That's all. It's like we are moving into the zone of where statins are, you have to prescribe say moderate intensity or a high intensity depending on the setting, not depending on the value. So that is how the glucose management also has come. Don't go by the value of A1C, go by the setting of the patient and please prescribe.
Okay. So you would like to place the combination therapy irrespective of the HbA1c level because of the benefit of less hypoglycemia, means no hypoglycemia.
Yeah, you are correcting the pathophysiological defects
Yes.
and without causing any problem to the patient.
Yes, sir. Well, it has been seen that the majority of the patient who are diabetes, they are also having the hypertension and lipid issues. So for that, they are taking some other drugs for anti-hypertensive or the hypolipidemic drugs along with the metformin and these sulfonylureas. Let's say if you want to shift the patient on the combination, so what measures you want to tell the recommend a patient so on the other drugs to be taken, that is hypolipidemic drugs and anti-hypertensive drugs.
See, whenever you are looking at managing the diabetes, number one, manage patient as a whole, looking at BP, lipid, all the drugs. I mean,
Yes.
most of the times I always ensure to write everything in one prescription so that he may be visiting a cardiologist, he may be visiting anybody, but so that the entire drugs are there in one sheet of paper so that everybody sees what is going around, number one. Number two, as I said, as you should intensify the therapy depending on the need, you may require to de-intensify the therapy when you have achieved your objectives.
Yes.
So if somebody has got a good, as I said, if suppose you have started at 7.5, you have achieved the objective of say maybe 5.6 or maybe 5.5 also, you may consider stopping. You may consider stopping one by one and keep the patient under follow-up and see. For all you know, patient may have started having good say weight reduction and then started good lifestyle modification. So as long as the patient is monitoring under follow-up, you can safely de-escalate or escalate vice versa. So there is no problem in that. Keep that whenever there is a doubt, you obviously reduce the anti-hypertensive and even the hypolipidemic as well. So that you generally do.
Yes. Well, thank you, Dr. K.V. Harikumar, for dissecting the topic very well and providing your valuable beneficial answers on the questions where definitely our viewers will have benefit to know control the blood pressure along with the diabetes and some other parameters in their patients. So definitely this cross connect and your perspectives will help them to see their patients benefit. So once again, I would like to thank you for your valuable times and your presence for this cross connect. I would like to thank also our Imagica Health team for their contribution for this webinar to be happen very well, and our marketing and sales team from the Lupins Limited. So thank you all of you for your presence. So any closing words until or Senthil, do you have any closing words? Okay, so with this, I would like to close the session. Thank you, Dr. Ramalinga Srinivasan and Dr. K.V. Harikumar for your presence for today's webinar.
Thank you, Dr. Kunal. Have a great weekend. Thank you, Dr. Srinivasan. Bye.
Thank you, everyone, for your patient listening, and thanks, Kunal and Dr. Hari Kumar, for your presentation. Thank you all.
Bye.
So,